What I'm going to describe is a approach. We can call it soft tissue approach to periodontal regeneration, which has the main goal to minimize gingival recession. Minimize gingival recession means that we leave the soft tissue exactly in the same position where we find them at the time of the first visit. So we leave as much as possible space between the soft tissue and the bone for the blood clot formation, blood clot stabilization, and in order to increase the bone regeneration. So the true objective of periodontal surgery and non-surgical phase in periodontal regeneration is to minimize gingival recession. By minimizing gingival recession, we can increase the potential for new connective tissue, new bone formation. Obviously, this respect for the soft tissue height and thickness must start, as I told you, from the time of the first visit. Because most of the time, patients are sent to make non-surgical phase consisting on scaling and root planing. Then they are re-evaluated, and if there's still some defect, a surgical procedure is performed. And this is a good way, obviously, for thinking, but in my opinion, this can be dangerous in the case of vertically bony defect. It's very important to identify this defect that has a great potential for periodontal regeneration, because if we send this defect to the non-surgical phase without identifying them and selecting for them a different approach, the risk is that as a consequence of the root planing procedure that is done in order to remove the pockets, that is done in order to remove the infection, can also remove the soft tissue. And this is because in the absence of bone and in the presence of not so much thick soft tissue, obviously the soft tissue during the healing due to the trauma of the root planing procedure and the non-intentional curettage we can create on the soft tissue on the soft tissue wall of the pocket, they are going to shrink. Obviously, from this situation to this situation, we have an improvement in the periodontal condition. This improvement in the periodontal condition is that we have less pocket, and we have a greater facility for the patient to clean the area which was a pocket before. But this is called resective surgery. In this case, the morphology of the defect, the presence of the vertically bony component allowed us to have regeneration. And so now that the defect is exactly the same because it does not change as a consequence of root planing, the possibility to make regeneration and to give a patient an aesthetic outcome, which is good for the patient, starting from this condition, is almost impossible, or let's say much, much, much more difficult with respect to starting with a different situation, with a different height of tissue, and with different amount of keratinized tissue. The most important aspect that you have to evaluate between these two pictures is that despite there is an improvement in the color textures due to the elimination of the inflammation, but the whole amount of keratinized tissue which was present before, which was more than 5 millimeters, is now almost completely disappeared. We have less than 1 millimeter of keratinized tissue. So in order to achieve a good aesthetics, for example, I should place this tissue and curl in advance much more, as much as I can, in order to cover also the gingival recession. But unfortunately, due to the non-surgical phase, I've completely lost also the papilla. You see that the papilla here was covering completely the cement enamel junction of the lateral. Now the cement enamel junction is exposed for about 3 to 4 millimeters. And this loss of papilla height, there is no way, there is no surgical procedure that is able in a predictable way to increase the position of the papilla together with achieving some periodontal regeneration and bone regeneration. So this outcome is a very good outcome if my objective was the resective therapy. So if I want to create gingival recession, facilitate the plaque control by the patient and reduce the pocket. But this is not my objective. When I see this patient, I see that there is a vertically bony defect. I see that there is a perfect quality, a perfect characteristic, a perfect amount of soft tissue all around. My objective is not a resective surgery. My objective is regenerative approach. So if you make the traditional root planing procedure in a patient in which there is the potentiality for regeneration, you risk to go exactly in the opposite direction, that is the resective surgery. So we have to be very, very careful how to perform non-surgical phase in this patient, because the non-surgical phase has the main goal not to reduce the pocket. So we don't need to make any root planing, but to get rid of inflammation with no gingival recession at all. So the non-surgical therapy in the treatment of vertically bony defect has the goal to get rid of inflammation, so to get rid of bleeding on probing, and we don't want to have any reduction of the probing pocket depth, any new bone formation, because this is something that can be achieved through the surgical procedure that will be performed 4 to 5 weeks after the non-surgical phase. This non-surgical phase is done with the main objective not to touch the soft tissue at all. The soft tissue wall of the pocket must not be touched, and on the other side, we want to get rid of the bacteria which are colonizing this pocket in plaque, toxins, and also which are colonizing the calculus, which is present inside our pocket. We have different, this is ultrasonic instrument of piezoelectric ultrasonic instruments. They are of different shape, different length, and different efficacy, especially in removal of calculus. You know that plaque and toxins are very loosely attached to the root and to the calculus, while calculus is very tightly attached to the root. So while it's very easy to get rid of bacteria, toxins, and plaque, it's much more difficult to get rid of calculus. The point A is the typical tip that is used for the non-surgical phase. That one we use, for example, when we want to make a supragingival scaling, because this point is so short, it's so wide, they vibrate so much that they are extremely effective in removal of the calculus. If we use, and you look at this movie, if you use these ultrasonic points only for the first 4 millimeters, they are exactly of the same dimension of the probe. So what I do is to sign a notch with a burr on the external aspect of my point A at a 4 millimeter distance with respect to the tip of the probe. Then I put the probe in. I don't make it work until the reference on the external aspect is exactly at the level of the soft tissue margin, and only once this position, namely 4 millimeters down, is achieved, I start to work with this point in horizontal and coronal direction. Horizontal and coronal direction in order to make a perfect clean with the most effective point of the first millimeters of the pocket, which almost correspond to the famous supracrestal connective or supracrestal soft tissue. So in this way, you see that there is no bleeding at all because I don't touch at all the soft tissue, because my point is in contact only with the surface. Then I use the next point, and this next point is called P, and this P for the first 7 millimeters is almost exactly as a probe. So again, at 7 millimeter distance from the tip on the external aspect, we make a notch just as a reference. So we place our tip until this reference coincides exactly with the soft tissue margin. And once the tip is in position, in perfect contact with the root surface, we start to use in horizontal and coronal direction. So we go back even and repeat the instrumentation on that portion of the root which was already instrumented with the point A, and we make a very good quality of treatment because the P is a very good quality of point to get rid of bacteria, toxins, and also calculus for 7 millimeters. So we are even deeper, the suprabony component of the defect. We are already in the infrabony component of the defect at about 7 millimeter distance from the soft tissue margin. But there are also pockets that are much deeper. They are 11, 12 millimeter deep. And for this pocket, there is another point which is so thin, like a probe, for about 11, 12 millimeter. And so we make exactly the same reference on the external aspect of the tip of the probe, on external aspect of the probe. We insert it down, 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 until we reach the deepest portion of the pocket. There is no bleeding at all because we are only probing, because exactly the same diameter of the probe. When the reference here coincide with the soft tissue margin, we start to work, and again, we use this in horizontal coronal direction, and this is the best tip also to be used as the buccal aspect of your soft tissue, where in the absence of bone, the soft tissue is so thin that only the thinnest type of ultrasonic tip can be used in order to get rid of plaque, calculus, and toxins. Now, what is the only limitation to this approach? It is that in the deepest portion of our pocket, so we are speaking about 9, 10 millimeters deep, maybe since in this area we only use the PS instruments, we may have left some small remnants of calculus. Why? Because the PS is extremely atraumatic, but it's also less effective with respect to the point A. So if you ask me, is it possible to use only the point PS? No, because this PS point is not effective enough in removal of the calculus, especially in the most coronal aspect of the pocket, where leaving calculus is extremely dangerous because they are very, very close to the oral cavity. And so the PS can only be used in the deepest portion of the pocket, where if there is some small remnants of calculus remaining, this does not influence at all the healing of the soft tissue, especially of the suprabony component of the soft tissue, because the calculus is very, very far, if there is some, from the oral cavity where some bacteria can come. But there is also the possibility that during the use of the PS, some bacteria has been completely disgregate from the biofilm and from the calculus, but they are still in the medium, in the sulcus. So that's why at the end of the mechanical therapy, I always use this chip. This is a chlorhexidine chip. You can cut it, you can trim it according to the dimension of the pocket, and you use a pincet to apply it in the most coronal aspect of your pocket, and then once it is inside, you use the same probe in order to make it reach the deepest portion of the pocket. What does this perio chip, this is the name, it says a chip of chlorhexidine that is a slow releasing product of chlorhexidine for time, 1 week, 8 days, 9 days of continuous release of chlorhexidine. This is very important because if you leave some bacteria in the medium, in the sulcus, disgregate from the calculus and plaque during the mechanical therapy, this chlorhexidine can act as antimicrobial agents and destroy these bacteria before they can be eventually reorganized in the biofilm or in the calculus that was eventually left in the deepest portion of the pocket because you were not able to remove it completely. So there is a disinfection of the pocket also from a chemical point of view, which is done with the use of this slow releasing product of chlorhexidine. Now the patient has cleaned the pocket. There is no more bacteria, there is no more toxin, there is no more biofilm. If there is some bacteria remaining in the deepest portion, these are, let's say, controlled by the locally derivative of chlorhexidine in the deepest portion, and the only thing we have to do is to prevent recolonization of the pocket from the external aspect. Because yes, the pocket is still there. We did not make any root planing in order to make the epithelium to get in touch with the root surface and reduce the depth of the pocket. And so we have to prevent, since this is an open, quite open, even if the maturation of the connective tissue improved the adaptation of this connective tissue to the root, but there is still risk of contamination. And in order to prevent this risk of contamination, what we do is to ask the patient to use chlorhexidine rinse, as I told you, twice a day, locally applied for 1 minute for the whole duration, for the whole weeks before the surgery is scheduled. So from one side, recolonization of bacteria is prevented by the local application of chlorhexidine from outside, and the contamination from the inner aspect of the pocket is prevented by the locally delivered system of chlorhexidine. The time that lasts between the non-surgical phase and the already scheduled surgical procedure is 4 to 5 weeks. This is the time that the connective tissue, which was called granulation tissue, can now heal and be transformed in collagen-dense, mature connective tissue in the absence of bleeding on probing, but we don't have to wait too much. Otherwise, there is a greater risk of recolonization of the pocket, and so the risk of making again this non-surgical phase, which can be performed how many times you want, because you are not making root planing, you are not removing substance on the root, but you are just cleaning the pocket in the best way in order to achieve the best condition for the soft tissue at the time of the surgery.